everybody, and welcome to the ESID Grand Rounds webinar entitled Updates on Neonatal Screening for Primary Immunodeficiencies, Where We Are Now and How It Impacts Treatment Outcome. My name is Luigi Notarangelo. I'm the chief of the Immunodeficiency Genetics section here at National Institute of Allergy and Infectious Diseases at the NIH, Bethesda. And I have the privilege of moderating this session together with Dr. Fabian Hauck, who's professor of pediatric immunology and hematology oncology at the Van Hauner Children's Hospital and Ludwig Maximilians University in Munich, Germany. We have a very interesting session today. If I can get the next slide. Yes, please, with the speakers, yes. With three outstanding speakers, Dr. Jennifer Pak, Carsten Speckmann, and Annelotte Duintjer, who will cover three different aspects related to newborn screening for primary immunodeficiencies. So these are the topics that will be discussed by each of the speakers. Jennifer will talk about outcomes on newborn screening for SCID, Carsten on newborn screening for severe congenital lymphopenia, the experience in Germany, and Annelotte will cover newborn screening beyond SCID, the role of genetics. At the end of the three presentations, there will be a Q&A discussion with the speakers. Please use the Q&A box, not the chat box, to enter your questions. All questions will be reviewed and analyzed and discussed at the end of the meeting. I just want to briefly mention that this is an important webinar because there are many open questions related to newborn screening. Of course, it's important to know what has been the outcome of newborn screening so far, but there are differences in the goals of newborn screening, the way it is defined in different European countries, for instance, what the objectives are. There is the issue of TREX alone or TREX versus CREX combined. What is the role of genetics? When should genetics be applied? So lots of important questions that I'm sure the speakers will address. And with this in mind, next slide, please. It's my pleasure to introduce Dr. Fabian Hauck, who will introduce Jennifer. Fabian.
Yeah, thanks. So it's a great pleasure and honor to have Dr. Pak with us. Jennifer Pak is a professor of pediatrics and immunology at the University of California, San Francisco. And it is clear to everyone here that she has been instrumental in pioneering newborn screening for SCID, taking advantage of infant dried blood spots. But beyond that, Jennifer Pak conducts clinical gene therapy trials as well and is involved in treating Artemis SCID, for example. She's got a lot of merits on top on that. And the best thing to say to honoring her is just to listen to her and ask her questions later on. So I'm very honored to introduce Jennifer. Please go ahead, Jennifer.
Well, good morning, or maybe it's afternoon for you. Thank you for having me. Let's see, I guess I need to okay, so I hope this is the right view for everybody.
It is, Jennifer.
Okay, so I wish I had lots of profitable things to disclose, but not so much. And just to start this session, I want to review that SCID or severe combined immunodeficiency is called combined because it affects both the T cell and B cell systems. And this condition is characterized by infections and early fatality unless we can establish an effective adaptive immune system. And the very first way this was done was with a bone marrow transplant from a matched sibling, first conducted in 1968. And so that person is now actually 58 years old and is a father of three and totally healthy. So that shows that this is a treatable and potentially even curable disorder. The treatment, if it's a transplant, works best with an HLA matched sibling, but unfortunately, most individuals don't have this. And some patients are cured, like that original patient in 1968, but others get T cells and not B cells, or they may have dwindling graft over time and have late complications. So transplant is certainly not a perfect solution. Okay, let's see. And we know there are many, many genes that can lead to SCID, and I've listed the more common ones here. And I'm just doing this to show that there are different profiles of T, B, and NK cells, as you can see, but all of them are characterized by very low numbers or absent T cells. And that's important when we think about newborn screening. So then this is some data from the Primary Immune Deficiency Treatment Consortium in the US and Canada, which has collected very detailed data from patients in many centers to put them together in a way that no single center would be able to do. And this was a study with 240 SCID patients, and I'm just showing their age at transplant. And you can see it's a biphasic curve with a very early, smaller peak. And those were patients with a previous affected family member. So the infant in question was recognized very early, even prenatally, and treated before 3.5 months of life. Whereas the larger peak are sporadic cases, and they're generally discovered by recurrent infections, failure to thrive, and finally somebody gets the idea that an immune defect may be involved. And of course, many infants were never diagnosed with SCID or died before receiving a transplant. So they are not on this graph. And then this is the same study showing the survival of these individuals. And you can see that the survival is excellent for those who had those very early transplants, the ones who were recognized early. And on the other hand, in stark contrast, are the ones who had to undergo a transplant over 3.5 months and in the face of active infection. And this is not ancient data. This is actually since 2000. So the modern isolation and transplant procedures were in place, and we're still not doing well with this group. So clearly we need something to improve survival for them. And newborn screening would be needed to recognize them early. And this is just a summary of criteria that have historically been used, first proposed by Wilson and Jungner, for what makes a disorder or a disease eligible or suitable to include in population-based newborn screening. And this is how SCID has met the criteria, starting in 2008 when I and the Models and Immune Deficiency Foundation and many other people presented SCID as a disorder to the US Secretary's Advisory Committee to try to get it added or recommended for newborn screening panels. So obviously it's serious. Newborns with SCID appear healthy, so you can't detect them by exam. We didn't know the incidence of SCID at the time, although we certainly knew that there were certain populations, such as the Navajo Native Americans with a frequent founder mutation. And we do know that there's well-established confirmative testing and transplantation treatment, also ADA enzyme for that particular genotype. And as I just showed you, survival is better when treatment is early and without active infections. So in order to think of what would be a suitable newborn screening assay, we needed to turn to the dried blood spots that babies were getting collected already in order to make this a cost-effective proposal. And so we had to think of something we could assay in dried blood spots. And it turns out we were fortunate that there is this biomarker of T cell maturation in the thymus, which is that the T cell receptor gene, as it is undergoing recombination to make the individual T cell receptor molecules that are expressed on the cell surface, the gene rearrangement results in leftover fragments that are turned into circles because they have cohesive ends that are just the same as or complementary to the linear gene ends. And of course, the joining enzymes are present in the intracellular environment. So these fragments are turned into circles, which are very stable because there's no ends to be chewed up by DNases. And a PCR reaction can be performed across the joint of the circle, which is a unique fragment to these treks. And this one particular trek that I'm showing here is produced by at least 10% of T cells, or found in 10% of developing T cells in the thymus. And so it's very easy to detect this. And what it then shows is if there are plenty of treks, and those are the black circles in this graph, then the baby is making mature T cells in an appropriate way. And if you don't detect these, then there's trouble. And so that can happen because of a inappropriate dried blood spot that has, then this would require a repeat sample. But if there really is actual SCID, then you get undetectable or extremely low TREC copy number, whereas this control in this case is a segment of the actin gene is amplified well. And these are actual newborn cards that were archived by the state of California, and we were able to retrieve them after treating the patients, getting a consent form, and requesting the residual samples from the California screening program, which has never thrown out a dried blood spot since 1982, except if a family requests, which is very rare. So SCID newborn screening has been adopted throughout the United States, with all states doing screening by the end of 2018. And this is just to show that we have 50 or 51 different screening programs in our country. They are all state Department of Public Health run. So we've actually had 51 different experimental sets of data on how to design and run screening programs. And what has this all shown? So this is another analysis from the Primary Immune Deficiency Treatment Consortium, led by Monica Thakar and a lot of the SCID investigators in our consortium. And what we did was we wanted to study SCID survival through the decades and compare it to leukemia survival, which, as you know, has incrementally increased in a steady increase throughout the decades. It used to be nearly fatal and in about 6 weeks in the 1960s and early 70s, and then progressive improvements in treatment have led to a monotonic improvement in survival. And we were very surprised to see that that was not the case at all for SCID. And what you see in this graph is the different decades of SCID patient survival, and it stagnated between really 1990 and 2009, and only in the most recent decade did survival take a significant jump up to greater than 90%. And what happened to bring about this improvement? was the institution of newborn screening, because the other improvements such as isolation and better conditioning and so on had all been in place before that. And indeed, we were able to go back to these patients and analyze which ones actually were diagnosed by newborn screening, and their survival was significantly higher than those not diagnosed by that method. So this is a map of US and Canada showing all the programs are screening now except a tiny little bit of Newfoundland and Labrador. And we've sort of changed SCID presentation. It used to be like this with thrush, failure to thrive. This child had vaccine, strain rotavirus, pneumocystis pneumonia, and 5 different viruses, because of course they collect these infections and never get over them until an immune system is established. And on the other hand, this is a baby who was identified by newborn screening, was totally healthy, had 0 TREX, early treatment, and never had a single infection, never turned a hair. So of course, it's a little bit difficult to explain to families with this type of situation what a serious condition their baby has, even though she looks perfectly well. And we've learned through SCID screening that the incidence of SCID in the US is about 1 in 60,000 births, although it's up to 1 in 2,000 for the Navajos. And we've been able to learn a lot of other things with population-based newborn screening. And one of the important things that you'll hear more about shortly is that in addition to successfully detecting SCID, which is shown in a pink bar here, and of course, both typical and leaky SCID and Omen syndrome have been detected, we are finding other conditions with low T cells at birth. So this is just data from California. California has about 500,000 births per year. And so in the period of 6.5 years, we were able to screen 3.25 million infants and found that about 1 in 15,000 have T cell numbers below 1,500 per microliter, which is our definition of T cell lymphopenia in the newborn period. And of course, newborn T cells are normally higher than later in life. So this is age adjusted. And we found SCID in around 1 in 60,000, including typical and leaky SCID. And then these are some of the conditions identified with low TREX and low T cells that are not SCID. So the largest category is syndromes, including those with 22q deletion or intragenic deletion of TBX1 have DeGeorge syndrome. About 5% of the 22q deleted infants have T cells below our cutoff. We also found trisomy 21, which we were not, our genetics colleagues were not expecting. Ataxia telangiectasia, we find over half of the patients, but certainly not all. And it's not that the other half are close to the borderline, they have absolutely normal TREX and T cells at birth. And then a host of other conditions, importantly, many syndromes, and I think you'll hear more about those. There are also secondary effects such as hydrops, causes of vascular leakage with T cell loss as opposed to failure to generate T cells. And an important condition here is mothers receiving immunosuppressive therapy for autoimmune or malignant diseases during their pregnancy. And if those medications they receive cross the placenta, they affect the fetus. But these are all recoverable if the primary problem is addressed. And certain preterm infants, especially small for gestational age infants, can have low TREX and low T cells that resolve over time. And then there's this wonderful group of idiopathic individuals with low TREX and low T cells. Many of them, a third of them actually, turned out to have a syndrome, and so I'm showing them poured into this bar here. But the rest show that we still have genes to discover. Okay. So we keep being asked, why can't there be newborn screening for my child's immune disease the way there is for SCID? And newborn screening beyond TREX and CREX would certainly benefit patients with early identification and optimal management. And so we'll hear, I think, a little more about whole exome or whole genome sequencing that are being proposed and even piloted. However, I want to just highlight the role of sequencing in diagnosis, which is undisputed. And diagnosis is defined as trying to find what's wrong with a person who is already in front of you because of a phenotype or something making them present to medical attention. And this is as opposed to the population-based screening. So diagnosis and screening are very different. Screening is designed for everyone in the population. All infants receive newborn screening, and applying deep sequencing to this is certainly quite controversial. And for a host of reasons, not the least of which I just wanted to show is the great disparity in data that we have for people of different ancestries. And this is just an example from a 2019 paper where a lot of people enrolling in GWAS studies were tracked over time. And you can see the red are the Northern Europeans, who are by far the predominant population, with other ancestries being much less represented. And as you might expect, the effect of this is that the predictive accuracy of sequencing and finding variants is way better for Europeans than for other groups. And so this is showing relative accuracy with Europeans as 1.0. Americans are somewhat lower, as are South Asians, East Asians, certainly lower, and Africans extremely low at the 25% accuracy level of Europeans. So I think we have to rectify this unjust imbalance if we're going to use whole genome or whole exome sequencing in a screening mode. And I just want to end with a picture of our first, this is a SCID patient from the Navajo Reservation who we treated with gene therapy. And I'm showing this just to say, if a baby who comes from a hogan with a dirt floor and no running water can be rescued and successfully treated by newborn screening, then it can happen anywhere. And I've never been able to understand why Europe hasn't adopted this more quickly. And I just want to end with thanks to a lot of people and organizations who have helped develop newborn screening. And I'll stop there. Thanks.
Thank you, Jennifer. So may I remind again all attendees who wants to ask questions to post their questions in the Q&A box. And it is now my pleasure to introduce Carsten, who is a distinguished investigator well known to all of you. He is senior lecturer at the Faculty of Medicine of the Albert Ludwig University in Freiburg, Germany. And he works also as a consultant for pediatric immunology and hematopoietic stem cell transplantation at the Freiburg University Medical Center's Department for Pediatric Hematology Oncology and the Center for Chronic Immunodeficiency, or CCI. Carsten has made major contributions to the field of primary immunodeficiencies, both in terms of characterization of the natural history of these disorders, but also the implementation of novel and targeted therapies. and he's going to talk today about 6 years of newborn screening for severe congenital T-cell lymphopenia in Germany. You see here already one difference, not just SCID, but severe congenital T-cell lymphopenia. Fabian, take it away.
Thank you very much, Gigi, for the very kind introduction. It's an honor to give a lecture like this directly after Jennifer, who and the entire American community had a great impact on being us able to introduce this screening in Germany as well. As Gigi already also pointed out, I've chosen to change my title from SCID to a broader field, severe congenital T-cell lymphopenia, and we can maybe discuss, and Jennifer pointed already towards this, what may be benefits of other T-cell deficiencies to be detected, whether they are target diseases, bonus targets, or off-target. So let's see, it's not working to advance the slides, but it should be okay. So we started our screening in Germany in August 2019. As in most countries, however, it took a long time to get this politically done, and there were many people involved. I don't want to walk you through all these political hassles. It took us about 8 years. But I really like to point out that it would for sure have taken us much longer without the clear and convincing data that Jennifer was just presenting from the US experience, which made a great impression also on the political decision makers here. So we didn't have to come up with own broader studies. The topic, I think, is very clear that these patients deserve to be identified by newborn screening. Around the very same time as we were bringing up our screening, other programs were rolled out across Europe. You see here in green those nations that have an active nationwide prospective screening as a routine screening. You also see that most countries in Central Europe do have experience in screening, often yet still being carried out as pilot programs, yet many of these on a national level. So I think we can expect that in the next few years to come, this map will turn into green for most of Central Europe. Screening can be done very differently in Europe. Most countries, as in the US, focus on a track-based assays. There are a few countries that also look into CRAC, so also looking for severe B-cell lymphopenia. Sweden is also, for example, accessing CRACs, but just looking into the data when there is an abnormal track finding, so primary distinguishing between B- and B+ SCID variants. And as Austria, there might be more countries coming up to combine these PCR screenings with other diseases screenable by PCR, for example, SMA. In Germany, we also only look into tracks, with the speciality that we allow across the different states very different platforms, both commercially and in-house platforms, which makes intercomparability quite difficult because obviously there are also different track thresholds. Before I talk more in detail on the track screening program, I'd like to summarize some general figures on the newborn screening program in Germany, which is the largest screening program in Europe. It analyzes cards from approximately 750,000 newborns per year, covers 18 diseases, as most screening primarily metabolic diseases. SCID, as I mentioned, was added in August 2019, and sickle cell disease and SMA were added more recently in 21. As pointed out before, we have a very heterogeneous screening lab situation. There are 11, and some of them are partially run screening labs, which results in a very heterogeneous state lab distribution. You see here the different federal states. North Rhine-Westphalia, for example, which is population-wise the largest state, does not have an own screening lab even, but send cards off to 5 different labs, which can make follow-up and tracking of results sometimes difficult. Until January this year, there was also no systematic or national tracking system in place yet. This has luckily changed, but when we rolled out the screening, the pediatric working party and newborn screening working party were teaming up to put a system in place to initiate service to understand better how many and what kind of patients we will pick up. Until January this year, it was also the newborn screening initiating doctor or maternity nurse that was responsible to follow the results and to initiate confirmatory testing. This has also luckily changed. So times are different now, but when we started this screening, actually there was no systematic tracking in place, and the impact of newborn screening has actually been quite unclear for many of the target diseases. This is the algorithm that we have in place in Germany. It's actually very similar to the California screening and many other screening programs worldwide. There are 2 levels of track abnormalities: situation where tracks are completely absent, and if this occurs in a child older than 32 weeks, we call this urgent abnormal finding, and that should refer the patient to what we call a SCID center. In situation where tracks are very low but residually detectable, first a new card is requested, and if this is confirmed, this abnormal value should trigger referral for confirmatory testing to what we call a SCID clinic or SCID center. So what is this about? About this SCID center and clinics. This comes back from the pediatric directive on newborn screening that was issued by the Federal Joint Committee, the GBA, which is the highest decision-making body on political health decisions in Germany, that requested that confirmatory testing for these diseases should be carried out in specialized immunological institutions. And as for other screening, the GBA asked the key leading medical societies, which are the Pediatric Working Group for Immunology, the Pediatric Working Group for Hematology Oncology, Newborn Screening, and General Pediatrics, to team up to establish a suitable network. So these working groups establish criteria for such SCID clinics and centers, which split relatively evenly across our country to ensure timely and as local as possible referral of such patients, with clinics being centers experienced in primary immunodeficiency care and diagnostics and who have access to flow cytometry, and centers being highly specialized institutions also in the treatment, including transplantation, where identified children with confirmed diseases should always be eventually referred to. We also decided that within this network, we would conduct 6 monthly surveys, and we've been doing so from the beginning and are still conducting these surveys to see how many patients presented. We published first data on 2.5 years in screening, and in that past publication, we had 95% complete data sets on data on initial screening results and confirmatory testing. I have updated for this lecture this previously published data. So this is now a much greater cohort. This was updated in spring this year for the last time. So over this period, over the last almost 6 years, 5.5 years in this survey, we identified 44 children with SCID, 21 children that we categorize as leaky SCID, Omenn syndrome, or idiopathic T-cell lymphopenia. And similar to what Jennifer reported for the initial California screening publication, a significant number of patients with syndromal diseases. If we look into the genetic causes, probably as you would expect, 1/4 of SCID patients, of classic SCID patients, have mutation in IL-2RG, followed by ADA, JAK3, and RAC. Overall, the genetic detection rate from the beginning has been extremely high in Germany, yet the family history is only positive in 20% of cases. So really making the point that it's the screening and not good history taking during pregnancy that can identify these patients. This is the group of patients with leaky SCID, Omenn syndrome, and idiopathic T-cell lymphopenia. there were only 5 patients with idiopathic T-cell lymphopenia, and also the follow-up is not very tight, so we don't know for these whether some of these are eventually reversible, which we have seen in 2 patients. The patient with Omenn syndrome, as you would expect, have mutation in RAC, and there's 1 patient with IL-2RB. When we look into the syndromal patient, I will do this at the end of my talk in a bit greater detail in 2 slides. You see that the majority of patients have mutations in or genetic alterations in 22q11.2, other thymus defects, or well-described genetic entities for syndromal CIDs. Again, the genetic detection rate here is very high, showing that when you are born with a severe congenital T-cell lymphopenia, you're very likely to have an identifiable genetic cause. And also, as you would expect, the rate of positive family history in this group is much smaller, as many of these diseases occur spontaneously. When we calculate incidences from these numbers, we have very similar numbers to what other have been reported in Western countries. At the last call, we had about 1 in 69,000 SCID cases in Germany per born child. We also looked into results for confirmatory testing. This is a bit older data now, and this has also already been published before, but maybe just to mention this also here in this lecture, as you would expect, those patients with a classic SCID situation usually have absent tracks, so that's what we call an urgent abnormal value, as well as 2 out of 3 patients with Omenn syndrome, half of the syndromal patients, and all of those patients with very severe athymia and a need for thymus transplantation. Thymus transplantation have all been carried out in collaboration with the Great Ormond Street Hospital in London. The 1 SCID patient who had an abnormal residual track level, also as previously reported, has been a patient with a SCID. We also have identified, as previously published by others, 2 children with reduced track numbers from mothers who have been taking immunosuppressive treatment during pregnancy. Both of them recovered complete T-cell after birth. Just very brief here, focus for the confirmatory testing results for CD4 and CD4/CD45RA. So a marker for naive T cells is to really make the point how important it is to include naive T cells in the confirmatory testing. As you would expect, patients with SCID have very low CD4 counts, with the exception of this patient here who has confirmed maternal fetal transfusion, but all SCID, of course, including this patient, almost lack completely naive T cells in the same way as patients with Omenn syndrome, although in this leaky SCID population, obviously CD4 counts can be almost close to normal. Also absent naive T cells in those patients with very severe athymia, otherwise in this cohort of patient more variable, but significantly reduced T cell and CD4 counts. We also published some early treatment data. Again, this has been published, and so this data is also a bit outdated and was here showing summary that we published in 23. Manfred Hönig is currently putting together this data in more detail in a specialized registry focusing on outcome, the GPOH SCID registry, and will present this in upcoming meetings. But just to also show the great impact that this screening had already early after short initiation of screening, we have a survival of 95% in the SCID patients. The majority of patients, 80%, have been transplanted within 4 months, so very early. The survival has also been excellent in all patients with leaky SCID who have a transplant-accessible disease, for example, cartilage hair hypoplasia, and has been in particular excellent in all patients undergoing thymic transplantation. I take care myself for 2 of these patients who have been transplanted early in 2019. And both, as well as other thymic transplant patients, are off immunoglobulins, show a very good immune reconstitution, no significant autoimmunity, really showing also the good outcome if we identify and treat these patients very early. The death that we occurred in identified patient was one SCID patient who had an paraflu infection prior to HSCT, again pointing towards the importance, of course, of isolation and prophylactic measurements, also in the age of newborn screening. We had two patients. You see here a picture of one of them with extremely early, basically in utero onset of Omenn syndrome. Both patients deceased despite very early diagnosis and initiation of immunosuppressive treatment. However, really making the point that identifying these conditions really helps, of course, to counsel the family, provide access to genetic counseling, and understand what has been the problem in these patients. And then we observed 8 deaths in this former analysis in patients with syndromic diseases, all of non-immunological cause. In particular, cardiac issues have been here the main cause of death. As pointed out before, I want to say a few last words on this group of syndromal patients. These are the last 2 slides of my talk. This is data that is currently unpublished, kindly provided by Lea Grafen from the group of Sujal Ghosh from Düsseldorf, who has been putting this together for the pediatric working group, covering an analysis of, in this analysis, 77 patients with syndromal CIDs identified by newborn screening. So what I've shown you before here a bit in a more systematic and nicer graphical presentation. About 2/3 of those patients identified have thymic defects, in particular 22q11.2 microdeletion, FOXN1 charge association, and then in the non-thymic deficiencies, we in particular see cartilage hair hypoplasia, a few patients with T21, AT, and individual other rare conditions. If we look into clinical presentations, first, you may assume that syndromatic diseases are particularly frequent in preterms. This is not so much the case. Actually, only 5% of these patients were born before 32 weeks of gestation. As you would probably expect, a relative high number, around 50% of these patients have congenital heart defects, yet only 14% have such a severe heart defect that it requires intervention. Otherwise, in this graphic, you see the very broad picture of various clinical problems. Interestingly, I think that autoimmunity is actually not so common, and generally, of course, a very broad picture, also depending on the underlying genetic cause. If we look into what has been done with these patients, what can we do with these patients? I think this is a very important issue, because also if many of these patients may not require a definite treatment like thymus transplantation or bone marrow transplantation, depending on the underlying cause, of course, they have severe T-cell lymphopenia, and there's many effective and easy things we can do. The easiest things, probably not listed here, is to withhold live vaccines, including rota vaccination, which is given very early in Germany and has been one aspect also discussed politically, why we think that these patients are really or should belong to the group of target disease in this screening. Severe lymphopenic patients, of course, benefit from pneumocystis prophylaxis, which has been administered to about half of these patients because they had severe T-cell lymphopenia, as well as a third of these patients had severe hypergammaglobulinemia in need for immunoglobulin replacement therapy. 8% of these patients underwent bone marrow transplantation. These were in particular patients with cartilage hair hypoplasia, and 6 patients in total, 8% of the cohort, have received thymus transplantation. Again, as I mentioned, all carried out in London. You see here the predicted psychosocial development impairment, which has been observed in about half of the patients, or you can also see here that half of these patients have a predicted normal psychosocial development. And most importantly, survival looked at distinguished for patient with thymic deficiency and non-thymic deficiency. And you see overall, this is really excellent. And therefore, of course, also important to identify these patients to protect them for example, MMR vaccination, and to identify them and provide prophylactic care. So this is already my summary slide. I hope I could convince you that this newly founded RP network of CID Center fosters timely identification and treatment of affected patients. The incident of SCID in Germany and other severe T-cell lymphopenia causes is comparable to other Western countries, and again, also in Germany, higher to what we previously anticipated to the era prior to screening. The genetic detection rate is high, greater than 90% across all entities. Identified SCID patient undergo early HSCT. There's currently a more detailed analysis on its way. Patients with syndromal CID have very good access to treatment pathways, including thymus transplantation and good outcome. And I think this is really encouraging to see this now also in an updated study. No screening is perfect and needs continuously optimization of the screening process in Germany. That can have in particular view, of course, also on the harmonization of the variable PCR platforms. We've made great achievements and improvements on the tracking process, which has been completely changed earlier this year. On a European level, I think it would be very nice to really follow up these patients also long-term. For example, in existing registries like the ESID registry, to have harmonized data sets to follow also these very rare children, for example, with idiopathic T-cell lymphopenia and yet not understood underlying genetic cause. There are many people I need to thank in this context, people from various medical societies who were involved in setting up the political process and initiating the screening, as well as the colleagues from the screening laboratories, and most importantly, the clinicians in the CID clinics and networks who see the patient and provide the data that I just presented to you today. Thank you very much for your attention.
So thank you very much, Carsten, for this comprehensive talk, including sharing unpublished data with the community. Just a reminder, please prepare your questions in the Q&A section, and we will have the discussion at the end once all the presenters have presented their data. It's my great pleasure to introduce Annelotte Duintjer. She is a PhD candidate at the Department for Pediatric Immunology in the Willem-Alexander Children's Hospital in Leiden, the Netherlands. She's currently doing research on newborn screening for inborn errors of immunity, specifically on the role of genetic testing. Annelotte studies the potential application of genetics both as a second-tier test to optimize the current screening program for SCID and as first-tier test to maybe in the future enable the inclusion of other inborn errors of immunity in the screening programs as well. So Annelotte, please take it away.
Yes, thank you for the introduction. I think you can see my screen. So in the final talk of today, I will be talking about newborn screening beyond SCID and the role of genetics. And yes, and why are we interested in the role of genetics? Well, due to the rapid technical developments and increasing cost effectiveness of DNA sequencing, global interest has emerged in the potential role of genetics in newborn screening. And it has now become possible to sequence entire genomes from only limited material, for example, from dried blood spots, for a decreasing amount of costs. And here's just an overview of some of the projects on genomic newborn screening that are currently being conducted worldwide, and including also some larger pilot studies on whole genome sequencing. And genomic newborn screening has the potential to improve current newborn screening programs as a second tier, for example, a newborn screening for SCID, but also as a first tier has potential to expand newborn screening programs with diseases that would benefit from early detection but lack a good biomarker to be detected in current conventional techniques. for example, for some of the inborn errors of immunity. And this was a paper that was published last year in Nature Medicine. And this even states that every baby deserves access to genetic screening. And this is quite a statement to make and really makes you wonder if this is what we would want for patients with inborn errors of immunity. And although the technical possibilities seem to be endless, it is important to be critical about these developments, which would eventually influence the whole society. And currently there's a high participation rate in newborn screening programs. In the Netherlands is around 99%. But this could decrease if societal acceptance of genomic newborn screening is not widespread. And this is, of course, something we should really prevent, and makes also that these developments should be carefully handled and studied in a multi-perspective way. And this is also what we want to do for inborn errors of immunity with the SPRING project. And this is a project which was initiated and is led by Dr. Miriam van den Burg from Leiden. And SPRING stands for Shifting Perspective on Screening for Inborn Errors of Immunity with Neonatal Genetics. And the aim of this project is therefore not focused only on technical implementation of genomic newborn screening for inborn errors, but is really to evaluate all relevant perspectives, including the clinical aspects, the costs, and also ethical, social, and legal implications, to eventually get better understanding on what role genome sequencing should play in a newborn screening program. And investigating all these perspectives requires a multidisciplinary approach, and therefore we not only involve researchers and healthcare professionals, but also people involved in screening, policymakers, and parents and patient organizations. And here's an overview of the full project with all the work packages. And as you can see, all these different perspectives and aspects are also incorporated. And the project consists of 3 phases, ranging from targeted sequencing of only a small set of genes to eventually also genome-wide approach, also for other inherited conditions. And the first phase of the project is where we explored the application of second-tier genetics in newborn screening for SCID to decrease secondary findings and false positive referrals. And we did this retrospectively with including 68 samples, newborn screening card samples of newborns that were referred because of low tracks from newborn screening. So this included SCID cases, but also cases with a different genetic defect or any other diagnosis that was made after referral. And on these samples, we performed targeted amplicon sequencing with a gene panel consisting of 105 genes, in which defects can be associated with low tracks and low T cells at birth. And this is a really schematic overview of the current newborn screening program in the Netherlands, with the 68 samples that we included in this study. Here we make a distinction between a direct referral, where tracks are lower than 2 copies per 3.2 millimeter dry blood spot punch, and an indirect referral where tracks are between 2 and 10 copies. And in case of these intermediately decreased tracks, a second newborn screening card is analyzed after referral, and a referral is then indicated if tracks remain below the applied cutoff. And in this cohort of 68 samples that we included, we had 5 SCID cases and 14 patients that had a different genetic defect than SCID. And most of these patients have a syndrome, including also patients with a 22q11 deletion. But these are also patients with monogenetic defects. And a large proportion of these samples consisted of patients that had a reversible condition for T-cell impairment. And other findings that were included were patients that were premature born or dysmature, idiopathic T-cell lymphopenia, and inconclusive cause. And finally, we also had some false positive referrals. If we would perform second-tier sequencing on all these 68 samples, the number of referrals will decrease drastically to only 10 referrals. And this will include all SCID patients and also 5 patients with a monogenetic inborn error of immunity. However, we do know that there are also SCID patients identified in newborn screening in which no underlying genetic defect is found. And Second-tier sequencing, of course, will require time, and you don't want to miss any SCID patients or delay the time until referral. And therefore, a third approach is introduced, and this would involve a safety net. And this will mean that newborns with tracks below 2 will still be referred directly, just as is now in current screening programs. And this will generally also include the SCID patients, of course. And in this way, we would only apply second-tier genetics to the patients with intermediately decreased tracks. But also with this safety net, we still see a significant decrease of over 60% with only 25 referrals instead of the 68. And in the next phase of the project, we'll be looking also at first-year applications of genetics in newborn screening. So not only for SCID, but also for other inborn errors of immunity. And this is a schematic overview to illustrate the difference between second-tier genetics and first-year genetics. Here is the current newborn screening for SCID. So genetic testing would then only be performed for the newborns with decreased tracks, abnormal tracks. And then only newborns with abnormal second-tier genetic results will be referred for further diagnostic workup, and thereby decreasing the number of overall referrals. But if you would apply first-year genetics, there's no supportive biochemical test anymore, such as the track assay. So you don't have a phenotype at all. And now that only this will be the only test that will be performed, this means also that there are much larger numbers of samples that needs to be analyzed, namely all the newborns that are participating in newborn screening. And most of these newborns will be healthy after all. So this will not only influence the technical feasibility of a first-year test in the lab, but also how to look at the data analysis and what kind of findings you want to report. And in order to eventually select genes for a first-year panel, we aim to take a stepwise multidisciplinary approach based on Delphi methods to eventually reach an expert-based gene selection. And first, we wanted to investigate what are important considerations for gene selection for experts working in the field of inborn errors of immunity. And we did this via questionnaires that we sent out nationally and internationally. And the questionnaires consisted of 10 statements and questions regarding key considerations for genomic newborn screening, which we adapted from the questionnaire of the ICONS. The ICONS is the International Consortium on Newborn Sequencing. And we carried out 2 rounds of questionnaires in which participants also were encouraged to provide arguments. And in the first round, multiple answer options were provided. And after this round, we had a national meeting with the National Advisory Board for Newborn Screening for SCID, the ANSCID. And this is a consortium existing of pediatricians, but also specialists working in clinical genetics, people working in the screening program, lab specialists, researchers. And there we discussed all the answers. And after this discussion meeting, we had a second round with only 2 answer options. So whether the participants agreed or disagreed. And in this round, also the answers and arguments of round 1 were included, with the aim to hopefully reach more consensus. And after that, we had 34 international participants from all over Europe, as you can see, and also 18 participants nationally. And all the participants came from different backgrounds, so pediatricians, people working in clinical genetics, and researchers. And I just wanted to provide 2 examples of statements that we included in the questionnaire. And these 2 statements were regarding treatment. And the first statement says that only disorders for which curative treatment, so stem cell transplantation or gene therapy exists, should be included. And the other statement said that also disorders for which symptomatic treatment is indicated should be included. And as you can see, the nationally and internationally responses were quite comparable. And the majority agreed that we should also look at the non-curable disorders, but with an efficient symptomatic treatment. And this was a statement where we did saw some differences between the national participants and international participants. This was regarding data storage. And the statement said that genetic data from newborn screening should be kept stored and be retrievable for a physician with patient consent in case there's a medical indication to request the data. And 100% of the international participants agreed, but nationally only a bit more than half of the respondents. And arguments that were provided were mostly regarding cost, stating that it would probably be more expensive to perform retesting, less expensive to perform retesting than to store the data for a longer period of time. And after this, we did a national survey to finally select the inborn errors of immunity for the first-year panel. And we presented all the disease categories according to the recent IOIS classification, and asked whether or not the participants would include the disease for first-year genetic newborn screening. And the participants were again from the SCID, but also the pediatrician immunologist from the LUMC. And again, we conducted 2 rounds. In round 1, answer options were yes, no, maybe, or I don't know, no opinion. And between round 1 and 2, we had again a discussion meeting with all the participants. And in round 2, also again, the answers and arguments of round 1 were provided. And after the 2 rounds, we had a final discussion within the LUMC. And we decided that for this research project, we then wanted to include the diseases for which the majority answered yes for inclusion. And based on this, we included SCID and HLH, CGD, also agammaglobulinemias, the congenital neutropenias, thymic defects, some immunoosseous dysplasias, and leukocyte adhesion deficiency. And just as with the second-tier study, we will be sequencing with a targeted amplicon-based approach with the gene panel. And as future steps, this summer already, we will be conducting a retrospective pilot study, and we'll be analyzing over 2,500 newborn screening samples. And with this high throughput, we hope to simulate a real first-year screening setting, and thereby aiming to evaluate first-year sequencing in a screening laboratory. And as we'll be analyzing a large number of samples, we are also exploring automation, both of library preparation, but also of the final data workflow. And with this pilot, we also hope to test and optimize a first-year variant filter strategy for inborn errors of immunity. I want to thank everyone involved in the SPRING project, a lot of people that we work with, and also including all the funders, but also all patients participating in the second-tier and first-year study, and also everyone involved in participating in our questionnaire rounds. And I'm happy to take questions and open the discussion.
Okay, perfect. So thanks a lot, Annelotte. And now we already have several questions in the, and maybe the first question I think would be most suitable for Jennifer. And the question is, what is your view on any other inborn error of immunity which could potentially be screened in the near future?
Well, of course, this is a complicated question because screening depends, as I showed in that overall chart of criteria considered by public health programs. You need a good test. And I think there's a lot of controversy about whether sequencing is a good test. Certainly panels of specific mutations were the way cystic fibrosis screening or hemoglobinopathy screening started, and that could be a start. I know there are programs, for example, in Canada, where there are founder populations with ZAP70 and ADA deficiency, where they've added those specific PCRs for those mutations to their newborn screening programs. And I think in localities where this is known, that's a very appropriate kind of addition. But I think this is an ongoing conversation. Of course, we'd love to have chronic granulomatous disease and all sorts of other conditions identified early, but you know, the cost benefit and the practicalities and the patient acceptance and ethics are all issues that have to be addressed.
Thank you, Jennifer. And I would also invite each of the panelists to raise their hand using the appropriate box if they want to add anything to the answers provided by other panelist members. So perhaps the second question would be for Carsten. Carsten, you did show some very interesting data on athymia. But what is the diagnostic workflow that you're using in Germany for diagnosing athymia? Do you have a unique agreed upon workflow?
Thank you for raising this question, and the short answer is no, we don't. And I think for the community that is that is an important task to solve this. Probably, I mean, obviously pointing towards what is the best system to distinguish severe congenital T-cell lymphopenia caused by a thymus defect versus a hematopoietic defect. So what we usually do, I mean, we are aware of a patient that has this issue that is typically B plus, that first of all runs over a genetic pipeline, and luckily this axis is really, really good. So I think first of all, many of these diseases are clearly genetically defined, as I pointed out also in my talk. So we have a relatively quick answer within 2 weeks very often on the genetic results. So in the clear genetic cases, this is answered there. And for those with severe athymia, we luckily had clear genetic results. We don't have a routine diagnostic test to like artificial thymic tissue to be tested to run this on, and then we always collaborate on a research basis. For example, reach out to the colleagues at Great Ormond Street Hospital, and I think that's something I would really encourage everyone to do, that in those cases that you cannot solve quickly genetically, and that is true for of course any patient in the schizophrenia 2. This is a situation where there's a fine line between routine diagnostic and research, and where we need to develop research tests to also more routine assays. And I think that would be really the time point to really then reach out to these very few centers that have high expertise in distinguishing this. But again, luckily, many of these can be genetically solved.
Thank you.
Okay, so the next question goes again to Jennifer. Do you have experience with a SCID-like, George syndrome-like phenotype and zero track as a result of untreated diabetes in the mother?
Yes, this is a well-recognized, uncommon condition, and we don't have a primary genetic reason for it. So it seems it may be an epigenetic phenomenon, and it's associated sometimes with a caudal dysgenesis or a set of other congenital anomalies. These patients have been treated by bone marrow transplantation successfully, and so I think there is a limited literature on this, but it's quite uncommon.
So the next question, actually, I would ask to both Jennifer and Carsten. Actually, it's a double-sided question. And the question is, could you comment on both false positive and false negative results of the TREC assay? What I mean is cases where actually TRECs are undetectable, but there is a perfectly normal number of T cells, including naive T cells. Or, on the other hand, TRECs detectable, but T cells undetectable or being very low. And this may also change over time, by the way. So have you seen such cases? What would be the causes? what could be the potential pitfalls or errors even in the diagnostic process? I don't know if you want to answer first, Jennifer, and then Carsten.
Oh, I was going to say Carsten first.
As you like, I can, I can maybe start. Well, it's a very specific and good test beforehand, and also the newborn screenings are very happy with it. They have other tests that cause more trouble. So I think initially what has been reported and sort of been solved, I think, because people are not doing it so much, is if you use heparinized blood that can interfere with the track primers. So there are situations where you get a false positive. Actually, it was the first child that we've seen with a positive screen. So presumably new tracks, normal T cell phenotype, and it has been very clear that this has been heparinized blood that was sent in, and there are some platforms where the PCR reaction can be disturbed. Then there are some very curious situation, and I don't know, Annelotte, if you have been involved or know about this, because I think it has been first reported by a patient from the Netherlands that has a sequence alteration in the track sequence, so that the reaction because of a specific mutation, they do not bind. That is super, super rare. There has been anecdotally, I haven't seen the confirmed results, one patient in Germany over this entire screening period where this has been also observed. But that is, and I think, of course, that has been something in the screening community we have heard, and we've reached out to people screened. This seems to be extremely, extremely rare. Well, and then, of course, it's also the question where you set your threshold, obviously, whether you have a positive test or not. And you may, of course, and Gigi, I think you pointed towards this a bit as it might change over time. The screening may, of course, still miss patients that you may still classify as combined immunodeficiency. So when we talk about leaky SCID, what is leaky? I can just maybe say one very short story, pointing to the fact that we had these different labs in Germany, and the algorithm has changed, but very initially you could have a first test at one lab and confirmatory testing to be sent out by another one. And we had one patient who had on a first screen just a borderline abnormal screening, so he was called for a second test. And that card was then sent to another lab and was tested to be okay, so over limit, and patient was not followed, became symptomatic. A patient, I think, with DOG8, so a leaky condition, and was actually missed by this referral. Would have been in the limit if tested on the same platform he was initially tested on. So there are these leaky conditions that are bouncing around these thresholds, and wherever you set this, it might be different. And then it's an ethical decision. What is a target disease or not? There are European countries that are not very happy that you pick up syndromal disease because they say this is not a target disease. And if you say your target disease is really only true SCID, and then you may define, of course, also athymia or very severe syndromes to be SCID. If you talk about T cell numbers, then your program should probably go down extremely low with the track levels, because as I've shown you, the true SCIDs have usually no detectable tracks at all. Because if you set this very, very low, you get only these most extremes form, and the higher you set it up, it gets more blurry, and that's always and it's an individual decision country by country. So in Germany, for example, it has been discussed ethically very important to identify patients at risk. For example, if there's a national recommendation for a live vaccine like rota vaccination, you should not endanger children at risk. So the also threshold by the people in charge has been less hesitant to have a super strict level, but that again, that really depends on a political debate. What is your target disease? And I think that's, sorry for the long answer, but I think there are many aspects in this discussion to be considered.
Well, an interesting question, and again, it was a double-sided question. Jennifer, Annelotte, do you want to add anything, or are we good with Carsten's answer?
Well, it was great, but I would also add, so the TREC test is done before the phenotyping, and things can change over even a week or two. So you have to keep that in mind, especially some of these instances where, say, it's a secondary T lymphopenia initially, maybe with maternal azathioprine administration or something, then by the time you do get the T cells, they're already better. And same with the preterm babies, if they're getting older, their T cells may improve. And so you have to keep that in mind. And then I also think that each program, you have to remember that all these programs are run by human beings. You can have mislabeling of a patient, and this happens. I think the estimate is maybe 1 in 1,000 samples doesn't get labeled properly in many screening programs. So I think there are a lot of biological and technical and other reasons that have to be considered, but all in all, the TREC test has turned out to be the most sensitive and the most specific that our screening program has ever looked at. So they're thrilled with it.
Thank you.
Right. The next question is the question to all the experts, but maybe Annelotte can answer. What is your opinion regarding the inclusion of CRECs to NBS program?
Yes, I think, I think we are now currently also working on a clinical data study on XLA patients to also get more, more information on whether an early diagnosis of XLA really leads to improved outcomes, because that's of course what you want with this screening. And I think there are, as also as shown in Europe especially, like there are not a lot of countries currently including CRECs, and there are also, I think, more secondary findings even than with the TREC assay. And I think, at least if I speak from like the Dutch newborn screening, who really wants to decrease the number of secondary findings and false positive results as much as possible, I think when we should include CREC here, we would probably also need to look into some sort of second-tier testing to decrease the number of referrals.
Well, the next question is also maybe for Annelotte first, but any speaker can answer. So whenever you have patients with, well, infants with clearly abnormal or perhaps borderline TRECs, what genetic test would you use? Would you use a targeted panel? Would you use a whole exome sequencing, or would you use a whole genome sequencing? Where are we going?
Yes, that's a good question. And I think also a lot of studies think different about this. For our project, the Spring project, we decided to go with a targeted approach. So this means only sequencing the genes that we're interested in, and also limiting thereby the data analysis to the genes we're interested in. And I think this fits the scope of screening maybe more than when you look at a broader approach, and especially when looking at whole genome sequencing, because it's really a difference if you sequence the genes that you're interested in, or sequence the whole genome from a screening perspective.
Carsten, what do you do in Germany? Do you have one policy, or each center does its own way?
So for confirmatory testing, there is no national platform. More or less, each center refers the patient to the local platform. In real life, there's not too many, and there's one major lab where I will say 90% of the tests are run through, and this is an NGS-based panel. So we've agreed on what genes need to be in there. For example, it needs to include AT, so that we don't miss this. And as it is based on NGS, it also then opens to be available for more extensive analysis if the initial panel is inconclusive, or to plug in a trio exome on a second try. But that is probably what most do here in Germany as routine confirmatory testing, which, and Annelotte, what you refer to, of course, is also the per se genetic screening level is something completely else. And Jennifer was also referring this. I think ethically genetic makes a big difference if we are looking into a patient who has a phenotype, or if we look unbiased on a population level.
Jennifer?
Well, I think panels can be very cheap and very quick. So if that's the case in your locality, that's maybe worth taking a look at first. And I think these days, many labs are not doing a captured exome anymore, but are actually doing a whole genome and then in silico producing the exome from that, which is a better exome. So I think this is an evolving field, and people just have to keep an eye on the continuing lowering costs and also what's available.
Right. So the next question is actually touching upon an entire field, and it is, what is your approach to the early detected AT cases? And we know that AT is a very dynamic during the last 2 or 3 years. So maybe Jennifer, you are very experienced. So what are you doing with AT babies picked up by NBS?
Well, of course, ataxia telangiectasia is the least favorite disease that I can imagine to be detected by newborn screening, at least up until now, because the treatment really has been only supportive, and actually in most cases the immune system isn't the primary cause of disability, but the children experience ongoing and more severe neurological and complications. We did have a patient who was identified by newborn screening, and the father was very active and dedicated himself to trying to find a treatment for his child, and ended up going to Boston and had Tim Yu there, who has pioneered oligo, sort of a Band-Aid treatment to suppress the splicing abnormalities that are caused by certain mutations. And indeed, this particular patient had a mutation that was able to be addressed by his technique, and the child received intrathecal injections of this antisense oligo, and apparently has not progressed, and that's quite hopeful. Of course, that does not address the immune system, only the neurological complications. People have talked about bone marrow transplant for ataxia telangiectasia, but of course there is a DNA repair problem, and conditioning is quite risky. So that's not really been widely used. I think there are a couple of patients who developed leukemia or lymphoma as and then were transplanted, who had AT. And I think, we need to think about that, but right now the treatment options are quite limited.
Right. So Carsten, would you like to comment on vaccination in these babies?
Yes, I think that's an important point. I mean, it's not a screening for AT. It's a screening for patients with AT who also have very severe T-cell deficiency, and I think that is an aspect that is very important to envision when we identify these patients. We all have learned over the past 10 years, maybe these the causes for these dreadful rubella granulomas and other sequelae caused by live vaccines. So even though it's only supportive, I think the supportive care is important and can also help to in the further course of the patient with other sequelae. They have to have less impact if we can avoid severe infections. It certainly requires an extra portion of counseling and multi-professional work, which in generally, Jennifer, you also pointed towards this in your talk, is necessary in these families and patients that we now pick up without any symptoms. So this psychosocial aspects in screening is generally very important, but of course, very, very important in those where we identify AT. I must say that the few that I have seen, the families in this context have all been very thankful that we could do at least this supportive care for this severe combined immunodeficiency they have. Although we have made them encounter with the disease much earlier than if it would have presented clinically.
So the other question is about immunosuppressive agents during pregnancy, and in particular, the question is about use of steroids in the last trimester of pregnancy. Have you seen actually low tracks as a result of use of steroids in a mother? I may actually make this question a little broader. Have you ever seen low tracks in infants who had congenital viral infection, in particular CMV, which I know Jennifer is particularly interested in, by the way?
So I have not seen a case where the mother was receiving steroids and not other medications in addition, where the TREX were below cutoff. I'm sure that there may be some depression of T cell numbers, but and TREX, but not enough perhaps to reach the abnormal threshold for the newborn screen. And regarding CMV, I have not seen congenital CMV presenting with low TREX. I know there's a lot of interest in screening dried blood spots for CMV because treatment of congenital CMV may help decrease the incidence of deafness in that condition. And so, but the problem is that there's a lot of false positives. So there are a lot of babies with positive CMV PCR on their dried blood spot who do not, or who are not destined to develop complications. So CMV is a very difficult problem, but certainly a very severe problem when there is a T cell deficiency. And so I think this is why we advise stopping breastfeeding if the TREX and T cells are in that urgent low level. And nobody knows exactly what the level of T cells would be above which breastfeeding might be safe. And of course, we hate to interfere with breastfeeding because it's the best nutrition for almost every infant.
Thank you.
Okay, so I think there's a lot of questions that are already in the Q&A session, and there's a lot of questions we could ask and discuss. But for the sake of time, I think we should come to an end. And this means that we have, of course, to say thank you to all our speakers and to moderators. Especially thank you to the people who were joining us and asking questions. And then we have some announcements to make.
So let me remind everybody that the Journal of Human Immunity is the new peer-reviewed journal jointly owned by the International Alliance of Primary Immunodeficiency Societies, of IAPIDs, of which actually ESID is a founding member, and Rockefeller University Press. JHI is under the expert editorial guidance of Jean-Laurent Casanova as editor-in-chief. with Megan Cooper as deputy editor and a number of other distinguished colleagues as associate editors. First issue is already published. There have been already 25 papers published. We encourage you to submit your papers in JHI, knowing that in October it will be in PubMed. Every paper will be in PubMed. And so we expect also to have an impact factor soon.
The next announcement is the announcement of the SCID COPA Focus Symposium, which will take place in Vienna. And I think this is a quite good opportunity to listen and to talk to experts in the field of immunodeficiency, blood disorders, and cancer, because these disorders have a lot in common, not only in terms of etiology and pathophysiology, but treatment is more and more getting in contact. So this is a great meeting, and I encourage you to join it.
The next one is about the 2025 PID Care in Development School, which will take place in Split, beautiful Split, Croatia. This school is mostly oriented towards professionals in the need of expanding their knowledge in primary immunodeficiencies in their daily work. Due to lack of experienced reference centers for primary immunodeficiencies in the surroundings of their center. The school is open to all ESID members, and priority will be given to applicants from European countries that are less involved in PID awareness and have less resources available. The deadline is August 4th, so hurry up and submit your application.
And last but not least, of course, we would encourage you to get involved in ESID, become a member, get active, and get in contact with your community, because there's so many things to do and to learn. It's a never-ending story, and it's fascinating, and it keeps on fascinating us. So thanks for joining, and look forward to see you during one of the upcoming ESID events.
Thanks everybody again. Thank you.